Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI CME podcast. This one's CME. And today we're going to be talking about something very clinically relevant, which is potentially unsafe drug combinations in treatment-resistant cases. And with me is my very good friend and NEI colleague, Dr. Roger McIntyre. Roger, how are you?
Andy, good day to you, and always fun to work together and have this virtual, almost roundtable discussion with a hot cup of coffee on the round table. This is going to be a fun conversation today.
Absolutely. Yeah, I think we always have fun, and we sometimes produce some pretty good educational content.
Mm-hmm.
Let's see what we got here. Well, first of all, we have some learning objectives. We want to identify some potentially unsafe drug combinations that you might consider, especially for those treatment-resistant cases when, you're willing to accept a little more risk to try to get benefit. We're going to evaluate risks and benefits of prescribing such combinations and consider efficacy, adverse effects, and of course, patient-specific characteristics, and then hopefully develop some strategies to monitor and manage these patients. First of all, Roger, I think what we want to frame this as is when we talk about drug-drug interactions, I always think in terms of pharmacokinetic interactions versus pharmacodynamic interactions. Is that how you think about it?
It's exactly how I think about it, Andy. And just to put a color on that, again, the pharmacokinetic would refer to the potential interaction between drugs as a function of their convergence or their interaction at the level of drug clearance. And again, we think about drug clearance as phase 1, phase 2. Phase 1 being the oxidation, redox, hydrolysis reactions. Phase 2 being the conjugation with glucuronides or sulfates or acetylation. So we have a very complex, I call garburator in the liver with respect to phase 1, phase 2. That's often when we talk about kinetics, Andy, you should know. And then the dynamics would be at the point of receptor target. So if we have two drugs, for example, two D2 receptor blocking agents that are co-prescribed, that's a pharmacodynamic potential as well. So I agree. I think this is exactly how I think kinetically and dynamically, and they're not mutually exclusive.
Yeah, no, you can have both. So pharmacokinetics, the way I was taught, is the body acting on the drug. Pharmacodynamics is the drug acting on the body, just to think real simply. And pharmacokinetics is more than just the metabolism. The whole ADME, we're taught that it's ADME, absorption, distribution, metabolism, elimination. There can be interactions at any of those levels that we can talk about. For instance, something we don't talk about is PGP transporters. PGP interactions is one that's, we always think about liver. I agree with you. And then pharmacodynamics, certainly receptors and also overlapping side effects if you have two sedating drugs and so on. All right. So I think we've talked about that. So let's start with depression, Roger, the area that you know so well. What would be something that would be potentially really unsafe? And I'll throw out an example. It seems like all of our package inserts, it says, don't give it with a monoamine oxidase inhibitor.
Yes, that's right. Yeah, and that still is in as you said, package insert, it seems, and that still is sort of top of mind for every clinician, the co-prescription of a irreversible, non-selective monoamine oxidase inhibitor, phenylzine tranylcyprine, with, for example, an SSRI as an example. Now, some colleagues might be saying, hang on, is this the Stone Age? Is Andy and Roger still prescribing those like erstwhile medications? Yeah, we are. These are still medications we not infrequently prescribe in very difficult to treat situations. But Andy, this is an interesting story. I remember when I was a resident, I was told, thou shalt not prescribe MAOIs with tricyclics. And of course, I stayed in line. But then we discovered something of a little color to this. In other words, if the patient's already on a tricyclic, such as desipramine, nortriptyline, and you add the MAO to it, that could be safely done. But conversely, you could not add the tricyclic to the MAO, so to speak. So I think that look, the takeaway message for all colleagues, let's not prescribe male inhibitors with SSRIs, full stop. But when we work in tertiary centers, seeing very difficult to treat cases, people with a lot of experience with this, what we find is we end up threading needles that are not needles we choose to thread, but needles that are a little more nuanced, and there is some nuance to some of this. Another example, Andy, in the mood disorder area would be lamotrigine. Do I prescribe lamotrigine in Valproate patients? If patients say Valproate, I do. I prefer not to, because Valproate could decrease. So lamotrigine and Valproate have a drug-drug interaction, and specifically, you could see an effect on lamotrigine's bioavailability, increasing the risk of cutaneous syndrome, Stevens-Johnson, toxic epidermal necrolysis, anticonvulsant hypersensitivity syndrome, but we do it in some cases. So again, I think that life would be easy if life was just black and white rules. And for the most part, I think people should have black and white rules, but there is nuance in very specific situations.
Yeah, I like that Valproate, lamotrigine. Valproate interferes with the metabolism of lamotrigine.
Yes.
Interestingly, oral birth control pills speed up the metabolism of lamotrigine. And so there have been some accidental pregnancies in women taking, actually not accidental pregnancy, but breakthroughs in women taking birth control pills. So,
but Andy, just on that note, in the mood disorder area, this is not confined to the hallways of depression and bipolar disorder. When we look across many mental disorders, you and I are talking about drug-drug interactions or potentially dangerous drug combinations. Just to put a bit of maybe epidemiology on this, how common is polypharmacy in psychiatry? Well, it's common. And I often refer to a paper, Mark Olson out of New York did a lot of work on this over the years. And I was told a third of patients who are in the outpatient setting in psychiatry are receiving 3 or more medications, according to Mark Olson's data from Columbia. So polypharmacy is quite common, and it's quite common as a chronic dosing paradigm. So this isn't just a one-off, here, take 3 medications for the next month and then bring it down to 1 medications thereafter. There's a sort of a Velcro effect here. People just keep adding more and more. So the trajectory is on the way up. But I think that in the depression area, I think that as we look to some of the newer entries, Andy, for example, we mentioned male inhibitors and SSRIs. We more recently have bupropion dextromethorphan combination. And in some of the potentially dangerous combinations would be, of course, treatments that affect seizure thresholds. For example, with bupropion as a co-administered agent. But you know what's interesting, Andy? Just on this, let me share your thought on this. We keep hearing about serotonin syndrome. Serotonin syndrome seems to keep popping up on people's phones when they prescribe a serotonin drug with another drug that directly, indirectly affects serotonin. How often have you gone to bed at night, Andy, staying awake, worried about serotonin syndrome?
I actually say it's very hard to cause it. I've only caused it once in my career, and I worked very hard to cause it, Roger. I had a patient on 80 milligrams of fluoxetine, and I was pushing trazodone to get him to sleep, and I got up to 300. And he came in staggering and red and diaphoretic, and I said, "Oh, that's what serotonin syndrome looks like." So it's not common, and you do have to work a little bit to cause it.
Yeah, that's true, and that's been my experience. Just maybe a couple other examples. I won't go through an exhaustive list, Andy, in the mood area. I think a patient taking combination olanzapine, samidorphan, we clearly don't want them taking an opioid agonist for reasons that I think that are abundantly obvious. Precipitation of a withdrawal, for example, that could certainly occur. That jumps out. And maybe just a kind of, I'm leaping around a little bit, so just forgive me here. A lot of colleagues listening in are giving patients or are caring for patients receiving IV racemic ketamine or intranasal S-ketamine. And again, I like the fact that we're using potentially dangerous combinations, because I think dangerous is certainly yes, but potentially dangerous is a different phrase. And for example, a patient taking a psychostimulant at this time is taking ketamine or S-ketamine. Do we do that? Yes, we do. A lot of our patients are on that combination, but that's why I say it's potentially dangerous only insofar as Some of these patients could have an increase in blood pressure. I got it, Andy, we've looked at this. We've reported on this in our team. About a third of patients can have an elevation of blood pressure, meaning 30 millimeters of mercury systolic, 15 diastolic. But it's not symptomatic, and it's transient. It tends to be, without symptoms or any kind of consequence. But it is a drug interaction that we do keep an eye on, because stimulants are, as you know, more than anybody else, are prescribed not uncommonly, especially in people who have depression or bipolar disorder.
Yeah. So it's interesting that the blood pressure elevation is very idiosyncratic. It doesn't always show up. You can have it down the road. So what I would suggest, and you tell me, is potentially would you have them hold the stimulant on the day of the ketamine treatment?
That's typically what we do. We typically hold it, and we also typically hold a couple of other medications that more in theory could affect the efficacy of ketamine, esketamine, benzodiazepines. I don't think we yet know whether they get in the way, so to speak, of ketamine's efficacy, but there's a theoretical concern about that. So we do hold those as well, maybe say 6 to 12 hours before treatment. But it's just something I bring up because blood pressure elevation is quite common actually with ketamine, esketamine, but it's not symptomatic or serious in the sense that it's not symptomatic, it's not malignant, it doesn't require any kind of tertiary type of care. It usually responds to just support. Sometimes a bit of a beta blocker or something like that is fine.
Yeah. Interestingly, Roger, in the prescribing information for S-ketamine, stimulants and monoamine oxidase inhibitors are not contraindicated.
Right.
So there's an interesting combo, but I think you still want to monitor blood pressure and be careful.
Yep, absolutely. 100%.
Let's go back to serotonin syndrome just for a second. I didn't want to gloss over that too much.
Yeah.
You did mention the dextromethorphan bupropion combination, and dextromethorphan, people not realize, is a modest serotonin reuptake inhibitor. And this is why in the label for this combination, it does mention the potential for serotonin syndrome. However, SSRIs are not contraindicated, but certainly caution is warranted. And I think caution is warranted with any combination of serotonergic medicines, just, not to poo-poo serotonin syndrome. But as you said, it's not something I stress over terribly.
Yeah. Myself included. It's something that I know I'm going to get an email from pharmacy, and I know I'm going to get an email from my patient.
Yes.
And just proactively say, hey, look, this is certainly a concern. We've got it. Here's some of the potential features of serotonin syndrome. And just be aware of it. And just for colleagues joining us, Andy, just a bit of a refresher, serotonin syndrome, a little bit like neuroleptic malignant syndrome, so to speak. There are aspects of rigidity and altered autonomic nervous system, temperature dysregulation, has a lot of GI aspect to it as well. I have seen it in my career, and I did see it in combination with a MAO inhibitor. More specifically, at that time, early in my career, a colleague had a case series of patients with meclobamide, which is a reversible inhibitor of monoamine oxidase. And I was, at that time in my career, not infrequently prescribing it with SSRIs, but did run into a couple of serotonin syndrome situations. So I think that is a concern for sure in that area. One final area, just before I forget, Andy, in terms of I'm sort of just doing a quick kind of practice reflection of patients in depression and bipolar. So as you know, I have an interest in GLP-1 receptor agonists academically, clinically, and we know these treatments are fit for purpose for their FDA indications, diabetes, obesity, heart, and kidneys. And we academically, as you know, have an interest in looking at whether these drugs could potentially be treatment or preventative strategies for mental and neurologic disorders, depression, bipolar, Parkinson's, Alzheimer's, drug, alcohol, and so on. So we have to do a whole podcast on this. It's such a cool area. But I think many of our colleagues know that these drugs do, of course, have side effects. Some patients can be really vulnerable to really bad constipation. And, so I guess it begs the question, in patients who are taking psychiatric medications that are known for constipation effects, of course, clozapine comes to mind right away. Right. Yeah, many, absolutely. And this can be very serious in some patients. This isn't just a little inconvenience, the kind of thing you see on a TV commercial for an anti-constipation drug. This can be pretty serious. And so I think that in a patient who's taking a drug like that, or let's say an opioid for pain, something like that, it's something in the back of my mind. Is it a combination I won't use? No, I'll use that in fact, clozapine and olanzapine can cause a lot of weight gain. So we will consider it, but it's certainly something, again, in the back of my mind, just consider. Of course, you resort to strategies around exercise, diet, lots of hydration, and so on. But that's something I think now in the world of psychiatry, this is now a drug combination we need to be aware of.
100% agree. And as you know, these drugs are being studied for neurodegenerative disorders, Alzheimer's disease, as you mentioned. We think those studies could read out later this year, actually, from Novo Nordisk. So we'll
that's right.
Have to see. You're touching on something else. Now you're getting into a real hot button for me and for a couple of our friends, Lessa Trome and Jonathan Meyer, and that's anticholinergics.
Yeah.
And I think this is an area, not only overt anticholinergics, there are many medicines that have covert anticholinergic effects. And when you combine them, I think this is a really dangerous area.
It really is. And again, I always like to sort of start off with epidemiology or kind of state of the union. I mean, how common are anticholinergics prescribed? And I think that there's a couple of answers to this. I think that if we're talking about people living with schizophrenia, many studies would say that about a third of folks living with schizophrenia are prescribed in quotes an anticholinergic such as Cogentin. Andy, I had the opportunity to be a contributor on an initiative about a year or two ago where the effort was to look at retail pharmacies. And for example, just over the counters, what percentage of medications at your local retail pharmacy have medicines that have anticholinergic properties, whether it be an anti-nausea drug or a motion sickness drug or whatever the case may be. And it's a lot, and it's in the hundreds actually of drug. Yeah, it's incredible. Now again, I think that we know that there's four sizes of things. There's large, there's medium, there's small, and there's totally irrelevant. And I don't know whether a lot of the sizes of these anticholinergic effects are totally irrelevant. Some are totally irrelevant, but I suspect some are not totally irrelevant. And so I think that there's a lot of anticholinergic burden out there. And that anticholinergic burden out there, I think, is a bit more than maybe has been previously known. And so, Andy, this is an issue. So, for example, if you are someone who is prescribed a dopamine receptor blocking agent, Andy, you and I we graduate almost a similar time. I was told when I was graduating, you should always give people Cogentin when you give them an antipsychotic. And that's not recommendations anymore. And second is that there has been this convergence of evidence that maybe in some cases, the anticholinergic could put the person at greater risk of two types of drug-induced movement disorders, that being akathisia, tardive dyskinesia. And I think that's probably true in some cases based on my read of that literature.
Yeah. Well, I like to say that we use anticholinergic medications for things they don't treat, such as tardive dyskinesia and akathisia, as you've said. We need to be very clear. The penes in particular of the antipsychotics have inherent anticholinergic effects, and so do the lower potency first generations, such as chlorpromazine and so on.
Andy, can I ask you a question on that?
Yeah, of course.
So I think that when we talk about psychiatric drugs and we talk about prescribing any medication, the first rule of medicines, don't harm the patient. Second rule of medicines, try to do some good for your patient. And those are rules that are just inviolate. We keep those rules close to our heart. At the same time, we're also treating very dangerous conditions and very serious mental illness. And so we have to balance risks. So, for example, we have a recent new entry, September 26th, the FDA approved Cobenfy. We have
I wanted to bring that up. Yeah, absolutely.
And here's a drug that has, the scientific word is cool. It has a cool mechanism of action, okay? Muscarinic M1, M4. This is a new chapter in psychiatric pharmacology. It's a presynaptic dopamine modulator, so to speak. And so this is the potential, not having TD on this drug, potential, but knock on wood, we'll see where it goes. But here's my question to you. Here's a drug that is augmenting or is, we'll say, modulating acetylcholine systems, M1, M4. Many patients take anticholinergics. I think leaving people on an inefficacious combination or a suboptimal combination, that has danger too, because the illness is not as best treated. So,
well said.
Are you concerned about any kind of compromise of efficacy in a patient taking xanomeline with a concomitant anticholinergic?
Yeah, let's talk about this from 2 points of view, peripheral and central. And first of all, when you talk about lack of efficacy, of course, I have to cite our very good friend Terry Ketter, a mentor to you and me, who one time in an ad board said, you know, it occurs to me, one of the worst toxicities of our medicines is lack of efficacy. And that has really rung true in my mind because our illnesses, as we know, are very serious and can kill people. And we're talking now about treatment-resistant cases. But to your point, the xanomeline-trospium combination, xanomeline is a central agonist at M1, M4. So if you pair that with an antagonist that gets into the brain, and most of them do, I agree with you. I think you're potentially blocking the efficacy. Now, trospium is a peripherally restricted anticholinergic, so it doesn't get into the brain. But now I'm really worried if I add the penes, let's say, which everybody's asking me, can I add this to clozapine? Can I add it to olanzapine? Now I'm worried about additive peripheral side effects, and particularly the worst one you mentioned is that ileus, which clozapine and olanzapine both have very scary warnings in their labels. Roger, little trivia fact, did you know that the package insert for quetiapine says it has a low potential for, it doesn't have much affinity for muscarinic cholinergic receptors, and yet the side effects clearly look anticholinergic.
Yes, they sure do.
And you know what? You had a hand in this story. I remember you presenting a poster on the active metabolite norquetiapine, which you found to be a norepinephrine transporter inhibitor. However, it also has very high affinity for muscarinic, so it really does have the active metabolite. So we don't think about active metabolites either. That's sort of another area. And I think what we're really saying is when you're getting to this point where we're going to use these heroic combinations, I think you've got to look at the prescribing information, particularly the drug-drug interaction section. I think that's an incredibly important resource.
Yeah, I completely agree with that. And, on that note about anticholinergics, we tend to have that conversation. Well, it's not only a conversation about tardive dyskinesia risk and the interaction with a dopamine receptor blocking agent. I suppose the other issue that comes up as it relates to VMAT2 inhibition, again, VMAT2 inhibition has become a therapeutic opportunity for deutetrabenazine and valbenazine, FDA indicated, among other things, in TD. Of course, there's other indications. But on that thought, in the package insert in the important safety information, for example, for valbenazine, it says that it does not prolong the QT interval to an extent clinically relevant at levels achieved with doses recommended. However, if the patient has let's say a slow metabolization phenotype, either because of Mother Nature or because it's been phenoconverted for some other reason, let's say they're taking an inhibitor, a strong inhibitor. Andy, for yourself, do you have concerns that, say, a patient took grapefruit juice or ketoconazole with valbenazine? For you, would you have concerns about the electrocardiogram?
Yeah, so you're talking CYP2D6 and 3A4 inhibition. Yeah. To be honest, I think QTC prolongation is a little bit of much ado about nothing, or at least much ado about not much.
Yeah,
I don't terribly, I'll be honest. And I think a lot of us prescribe drugs and don't realize that in the label it does say something about QT prolongation. Roger, do you know how much your QTC interval varies in a 24-hour cycle?
I gotcha.
I'm sure you know. It's 60 to 80 milliseconds at least.
Yep.
So when you're talking about a 9 millisecond, 6 millisecond, it's sort of a drop in the bucket. Now, I'm not saying it's not potentially an issue.
Right.
But what we're really worried about, of course, is a fatal ventricular arrhythmia such as torsade de pointe, which just having QT prolongation doesn't necessarily cause that. A lot of this came from, this was many years ago, you may remember, there was some antihistamines on the market. I'm trying to remember their generic names. It was Seldane and Hismanol, but I don't remember their generic names. And those guys were QTC inhibitors, but not terribly bad on their own. But when added to metabolic inhibitor, they had a huge widening, and there were some deaths from those guys. But that was, I forgot, it was something like 30, 60 milliseconds out. So that's a very good point. It's something to be aware of. Oh, here, let me tell you some of the other little piece of trivia, Roger. You know, in the labels, it says, don't give this drug to someone who has congenital long QT syndrome.
Yes.
Should clinicians be worried that they'll accidentally do that? No, those people start passing out in childhood. You will know who they are.
Right.
So I wanted to dispel a little bit of concern there. You mentioned something else that's interesting, and that is, pharmacists who are well-meaning often have these computer programs that spit out these drug-drug interactions. And, that is a little bit of a hassle to deal with. But what we need to do, I think, is document in the chart why we're doing what we're doing and that we're going to monitor and that the situation does justify this combination that we're using.
That's right. I completely agree with that, Andy. I think the point's very well taken on QTC. And I think in many ways, when you were saying that, I was nodding my head because for me, it reminds me a bit about blood pressure elevation with ketamine, S-ketamine. And again, the point is not that we think that blood pressure elevation of 30/15 or greater during treatment with ketamine, S-ketamine is somehow to be minimized. No one's saying that. What we're saying is it has to be contextualized. And these things are often transient with, for example, the blood pressure, it's asymptomatic. And to your point, when you look at blood pressure variability in an individual, for example, through, strenuous exercise, things like that, when it's transient and asymptomatic, we wouldn't be we're not concerned. So these are things that you just have to put in context. I've had colleagues of mine say, I have patients who have these transient elevations of ketamine, S-ketamine, blood pressure. I'm asymptomatic. They're doing well on the treatment. Should I stop the treatment? I said, no, I would not stop the treatment. Just on that alone.
Totally agree.
Etc. Yeah.
Well, I think also the issue of stimulants comes up. So let's address that. You certainly remember in Canada, mixed amphetamine salts was actually taken off the market for a little while because of this concern about cardiovascular safety. And subsequent studies have shown that that was overblown. You don't have to routinely do an EKG. You should monitor blood pressure and heart rate. You can absolutely use stimulants in a patient with a history of hypertension as long as it's managed and treated. And I would say probably the same thing with ketamine, S-ketamine, as long as the blood pressure is met. And this is funny. We talked about drugs to hold the morning of ketamine treatment. I would say you got to make sure they take their blood pressure medicine on the day of treatment, as an example. But, people are afraid of stimulants for a lot of reasons. And yet stimulants I have found to be extremely effective augmenting agents in certain situations. And another piece of trivia that our audience may have heard me say a million times, and you have too, I'm sure, is the first medication FDA approved in the United States for depression was Benzedrine or amphetamine, 1939.
Right. That's right.
So there is a history of using this as augmentation for mood disorders, certainly ADHD plus mood, ADHD plus bipolar. You're an author on the study of asenapine for young people with bipolar, in which ADHD and stimulants were allowed, I believe, Roger. I thought that was mind-blowing.
They were, They were allowed to be on the stimulants while they had bipolar illness.
As long as you're taking a mood stabilizer or an atypical antipsychotic, you're actually okay doing that.
Yeah, absolutely.
And there's two large data sets out of Scandinavia that showed not only does doing that not worsen the patient, they get better. Their cognition and mood both improve as long as the patient is reliably taking the mood stabilizer and the atypical. We talked about VMAT2 inhibitors. There's a concern sometimes about VMAT2 inhibitors with anticholinergics. And this happens a lot. Somebody comes to you on an anticholinergic. You think they have TD. What do I do? Well, there's a couple different schools of thought. You certainly can simply add the VMAT2. The valbenazine trials, I believe, were the ones, and now I'm confused. It was either valbenazine or deutetrabenazine that allowed anticholinergics.
Valbenazine,
It was valbenazine, A third of the patients were on an anticholinergic. And in that case, the VMAT2 was simply added. And, it's the old do one thing at a time. Some people would go the opposite direction and try to taper off the anticholinergic because, as you've said, that can worsen TD. So maybe you taper off and see what you've got and then add the VMAT2. I think the most important thing is to reevaluate the use of the anticholinergic. And at some point, whether before the VMAT2, personally, I would add the VMAT2, get that going, and then slowly taper off the anticholinergic and be ready to adjust my dose of my VMAT2. The prescribing information doesn't tell us what to do, but I don't see significant risks of co-administering those two. They certainly work in opposite ways.
Right.
But I don't see a risk co-administering those.
I agree. I don't either. But for the reasons you highlighted, I think that's when in a third of the people who were in the well-cited and well-presented Connect, this is the valbenazine study that showed its efficacy and safety in TD in the adults with moderate to severe TD. A third were taking an anticholinergic. I just think, look, there's a reason that can happen in some cases. I just think there just needs, like anything else in medicine, a good, thoughtful justification. But I don't think that's contraindicated. I completely agree with you.
Yeah, I think a lot of clinicians have become a little bit immune, though, to the risks of anticholinergic medicines because we give them out so often. And I always joke that an anticholinergic is like a benzodiazepine. Once the patient starts it, it seems like they never stop it. And, as people age, the long-term effects of anticholinergics certainly become more pronounced when we're talking about urinary retention, especially for us guys, for constipation, and then, of course, the cognitive impairment. So I really think we need to reevaluate our use of again, overt anticholinergics, which would be the ones we prescribe for movement disorders, but also the penes. You have to watch out for those. And then the less overt ones, as you talked about. I think, some drugs, even with modest anticholinergic effect, when you start adding them together, and a lot of our patients accumulate meds over the years, and, for blood pressure and statins and all kinds of things. So we do have to be careful.
Absolutely. And, this notion that cogentin can somehow serve as an antidote for specifically TD and akathisia was in psychiatry for a long, long time. And I don't think anyone had any intention to harm, but I think it just was a lack of knowledge or incomplete knowledge of the pathophysiology of those specific types of drug-induced movement disorders, and of course the pharmacology. And that's why there's been a push now to use this phrase drug-induced movement disorders more than EPS as an encompassing moniker. Another example of that as it relates to combination, I guess is a different type of combination, and that is that the combination of Valproate with fetus. And that's a big, and Andy, you and I were chatting with this recently at a meeting in Brazil that Valproate has been with us since the late 1800s. It really became a contemporary treatment in psychiatry in the 90s. You remember the famous Charlie Bowden studies in acute mania.
Sure. And
so
also
Valproate,
Paul Keck and Sue McIlroy.
Absolutely. And Valproate clearly has been an important treatment for many people with bipolar disorder. There's no question about that. It's an old drug.
Yes.
But I think that there has been a rethink, and just recently, my team looked at this in Toronto. We identified every study we could find that looked at anything teratogenic with Valproate. Of course, anatomic comes to mind, congenital malformations and neural tube defects, but also looking at so-called behavioral teratogenicity, children who were exposed in utero who now have, for example, behavioral problems, ADHD, things like that.
Neurodevelopmental disorders.
Yeah. And then thirdly, some of the cognitive effects. What's the effect on IQ? What's the effect on aspects of cognitive functions? And unfortunately, what we have found in our recent analysis we just published is a little concerning. And I didn't even know this myself, how high it was. Taken together, just on all three forms of teratogeny are elevated. Secondly, on the anatomical one, which is the one that's understandable, has received a lot of attention. The combined neural tube and major congenital malformations could approach in some studies 6 to 12%. A little higher than we thought. The other part, Andy, again, this is where I guess the why I thought of this with respect to cogentin, in the sense that I had always believed that folic acid, 4 milligrams in this context, because you're giving it as an antidote to Valproate, not 0.4 milligrams, which is what the general population's recommended as a prophylaxis against neural tubes. The 4 milligram antidote for Valproate hazard in terms of teratogeny has not actually been shown to be effective. That's theoretical. That's not actually really been shown to deliver on what we hope it would deliver on. So I think that there's another example where a safety aspect of a medication so known, we've been used in psychiatry quite routinely for 30, 40 years. Of course, it's been around for over 100 years. This is a drug that I think has really been reassessed. And in the UK and in France, there's been dear healthcare professional letters gone out saying, probably shouldn't use this medication at all. If you're going to use it, you have to have 2 independent consultants in the UK to agree with you. So, and I think, there's been many very, very, very well-informed colleagues here in the United States who are very expert on this area, who also, I think, would share the view that Valproate should be only used in reproductive age women under very, very select circumstances. And I think I'm kind of gravitating to that as well. So just as it's a different kind of combination issue, and it's more drug safety rather than drug combination. But I guess it's a combination of mom, fetus, and drug. It's a different kind of combination.
Well, absolutely. I mean, that question always comes up, Roger, drugs in pregnancy, breastfeeding. But let me circle back on this for a second. It's very interesting you say, I'm going to quickly circle back to the folic acid. Part of that may be, as you well know, folic acid and folate are not used by the body.
Right.
The bioactive form is L-methylfolate, which is converted by a 5-step enzyme process. Genetic abnormalities there are associated with depression. As you know, they're higher in people with depression. And because the L-methylfolate is bioactive, it's also what crosses the blood-brain barrier. And several anticonvulsants interfere with a different enzyme in that pathway. And so it's possible you're giving folic acid and the Valproate is actually blocking the pathway. So maybe decreasing the ability to get to the bioactive. So I always recommend L-methylfolate, and there are various forms of that. In that situation. And a good friend of ours, you remember, John Zajeka,
yes,
taught me that with lamotrigine, which I hadn't thought of as having folic acid issues, you have the same issue and you should. Yep. So when I prescribe lamotrigine, I always try to give L-methylfolate. I like to say that Depakote or valproic acid was state of the art for bipolar in the 90s and 2000s. But I think now it has fallen down quite a bit due to the risk, and we just have better options.
That's right.
We have such as lamotrigine. Our friend Jonathan Myers got us to reevaluate lithium. Atypical antipsychotics, which by all definitions are mood stabilizers.
Yes, for sure.
So certainly that. And you're 100% right. A newer study, I wasn't aware of your study, but another study that really influenced Europe showed that children born to mothers taking valproic acid have triple the odds of neurodevelopmental disorders. Yes. But here's the kicker, Roger. Children born to fathers taking valproic acid had an increased risk. So it's getting into the sperm, if you will. So
that's right.
Yeah, I think we do have to reevaluate that. Another one, another oldie but goodie, very effective that you and I have both been involved with is carbamazepine. And we certainly know there's a lot of drug-drug interactions there we have to worry about. It's one of the inducers of enzymes.
That's right. It's still being used. I mean, I don't prescribe that combination as much as I did when my career had started. Valproate carbamazepine combinations were actually very common in those days, less so now. And there is clearly an interaction. Valproate inhibits the epoxide hydroxylase responsible for carbamazepine, so causes this increase in this epoxide metabolite that can be quite neurotoxic. So that was always the issue when you were combining those. So carbamazepine would not only stimulate enzymes like 3A4, but it would also auto-induce its own metabolism. And then Valproate would also interact with carbamazepine, increasing the 10-11 epoxide. It was basically, frankly, it was a real drug-drug interaction, like a kaleidoscope with these two drugs came together, because they both were really fiddling with each other. But that point is well taken. Again, that combination, not as commonly seen as it once was. As you said, across the country, some studies, epidemiologic studies, are reporting out in bipolar disorder that the most frequently prescribed class of medications, not in every study, but in many studies now, is antipsychotics. So they are becoming, as you said, they're becoming sort of the cornerstone mood stabilizers for a lot of patients for good reasons, because many of them are.
Yeah. I remember the APA guidelines for bipolar in the 2000s said atypicals were only for acute use. Should not use them. And now we know they can be, as you said, the foundation. And certainly we know several of them are antidepressants. Roger, I've mused on this. All antipsychotics are antipsychotic, but they're not all antidepressant.
That's right.
Which I find fascinating. And that's understanding the receptor profile. You just got me thinking of something else when you said auto-induce its own enzymes. Paroxetine is a nasty little bugger too, right? And while we're talking about it, we need to remember fluoxetine, paroxetine, and bupropion are all CYP2D6 inhibitors. Sometimes we don't think about that. And many of our atypical antipsychotics are metabolized by 2D6 and or 3A4.
Yeah.
So I don't think we think about that. And then another thing that you and I talk quite a bit about that I think we need to really tell our audience is marijuana, especially CBD, is a 3A4 inhibitor and has probably many other pharmacokinetic interactions.
So on that note, Andy, just a clinical question, and this is something comes up not uncommonly across the country, in fact, around the world. In someone who says to the clinician, look, I not uncommonly will have cannabis in some formulation, smoking it, eating it, or have CBD THC. I'm also taking a CYP3A4 substrate like a aripiprazole, brexpiprazole, cariprazine, or lumateper. I mean, the list goes on and on. As a function of usual practice, would it be your usual practice just to note that in the chart and just advise patient? Or would you put that as a note in the chart and tell the patient, I want you to use a lower dose of the CYP3A4 straps, or use it less frequently? How do you approach that?
I have no trouble using a CYP3A4 metabolized drug in a patient that I know happens to be using any form of marijuana, CBD, THC. However, I'm absolutely going to be much more careful with my dosing. I'm going to start as low as I can and go slowly, put a note in the chart, advise the patient, monitor. It's yet another tool, if you will, for me trying to get them to decrease or even stop their use of marijuana. I'm a big believer in harm reduction. They may not be able to completely stop, but if I can get them to cut back on the use, that's got to be a good thing. So that's sort of how I handle it. I don't worry. I don't let pharmacokinetic interactions stop me. I don't let pharmacodynamic interactions necessarily stop me, as we've talked about. Yeah. But I certainly think carefully through them. I advise the patient. I document in the chart, of course. Yeah.
Yeah, it really is. And it comes up a lot now. I think it just goes to, I guess it's a statement about the paucity, the lack of research we have in the area. We certainly need more of that. We have so much on grapefruits and grapefruit juice, but not a lot on cannabis.
Yeah, I have to be careful, Roger. I live in Florida. The Citrus Growers Association gets mad at me when I say that.
But as I'm thinking out loud, just in terms of just kind of extemporaneously with kinetics, in the world of depression and bipolar, which has been my home throughout my career, some of these drug interactions, they cut both ways. Sometimes it can be your friend, sometimes it can be your enemy. Thinking about, we did a study many years ago, taking patients who were prescribed venlafaxine, and not uncommonly, they have sexual dysfunction. And back in those days, we had hoped bupropion could be an antidote. It doesn't really work that well as an antidote, but some people might. And bupropion, what we discovered was, it inhibits CYP2D6. And consequently, the ratio of venlafaxine to O-desmethylvenlafaxine was effective. So just so everyone's on the same page listening in, O-desmethylvenlafaxine, which is effectively Prestige or Desmethil, it's the active moiety. So when you're prescribing bupropion with venlafaxine, you're reducing the concentration of the active moiety. I mean, at least the principal active moiety. Conversely, when you add bupropion to dextromethorphan, that boosts the dextromethorphan bioavailability to half-life to allow target engagement on NMDA and sigma-1 and other receptors you mentioned earlier. So again, a drug interaction can sometimes be your friend and sometimes it can be your enemy.
That's right. Well, yeah, we should talk about that since we have what I call old wine in a new bottle meds or fun with pharmacology, and I would certainly put xanomeline, trospium, and bupropion dextromethorphan both in that category. And obviously the dextromethorphan bupropion is a pharmacokinetic interaction, whereas the xanomeline trospium is more of a pharmacodynamic interaction having to do with the cholinergic receptors. I think those two drugs really well illustrate what we're talking about, actually, Roger. So that's interesting.
Yeah, okay. They really, really do. They really, really do.
We need to talk about one other thing. And actually, can I go back to that for a second? We don't think of the favorable kinetic interactions. I have sometimes employed the strategy of using a 2D6 inhibitor to boost the blood level when I'm using the LAI, and one of the aripiprazole LAIs in particular, that sometimes I seem to run out of road. The dose isn't quite high enough or it doesn't last long enough. And I've added fluoxetine, for instance, which is long-acting, and get a boost. So sometimes you can play that game in a good way or to your benefit. But there is another thing we need to talk about here, and that is patient-specific characteristics. And I think we can categorize these in a couple of different ways. I think we need to talk about race. We need to talk about ethnicity. We need to talk about gender. We need to talk about age.
Yeah.
We need to talk about their genetic metabolic status, of course. Comorbidities, diagnoses. So what would you say? Where would you go with that?
That's such a great point. I think that, we have diagnostic biases across different race, ethnicity, and economic groups. And I think your point's well taken with respect to what we're talking about here today, pharmacokinetic, pharmacodynamic. I would not assume that studies that have been conducted on, Caucasian populations of normal body weight would extrapolate to other groups. Yes. And I think that point's well taken. Can I
just put a pin in what you just said? I don't think people think about habitus and body weight. That's an excellent point. Yeah. Certainly lipophilic drugs, of course, with more body fat, that's an issue. That's a really good point. Yeah, I mean, it
is. And I think that, for example, let me just walk through a thought. And that is that, we were talking a moment ago about, cytochromes, phase 1 systems, which is the oxidation, reduction, hydrolysis. Phase 2 is the conjugation interactions. Now, in our liver around the world, the prevalence of, so what we used to call fatty liver has a longer name now, is 25%. 1 in 4 global adult population is fatty liver. In the psychiatric population, depression, bipolar, schizophrenia is close to 50%. It's close to 50%. And that accords with the estimated prevalences of obesity, metabolic syndrome, prediabetes, diabetes in these populations. And so one of the thoughts, Andy, is if this is, we're having kind of a podcast here. I just want our colleagues to kind of listen on this thought. I don't really know where I've landed on this yet, but we know that some of these folks, because of the accumulation of fat in the hepatocyte, it can trigger an inflammatory reaction, which is known as NASH, non-alcoholic steatohepatitis. Everyone's heard of that. And that can lead to serious problems like fibrosis, and it goes downhill from there. It won't surprise anyone listening in that once you have that microenvironment of the cell, the hepatocyte inflamed, it's on fire basically, well, it does begin to affect the enzymatic activity, such as the cytochromes. And so one of the aspects I started wondering, and just to this point you mentioned earlier, because you kind of triggered the thought in my mind, we were talking about the cannabis. And we have this sort of, Donald Rumsfeld, known unknown drug interaction with cannabis in CYP3A4 substrates. And one of the thoughts I've had for a long, long time is that I wonder if there's a lot more CYP3A4 slow metabolizers than we think about, because if there is fat in the liver, half of the patients have fat in their liver, that's a fact, too much of it, that could cause maybe, yes, NASH, but NASH is full-blown, the house is on fire. But before you get to that, there already is inflammatory markers. And we did a little study about 4 years ago, which I didn't even know this, Andy, is that of all the cytochrome P450 enzymes, there's a whole catalog of them, CYP3A4 is a very sensitive one. Not sensitive as in emotionally sensitive, but sensitive in the sense that a little bit of inflammation in its vicinity, it starts to shut down. And it's really interesting because that would then lead to the possibility that many of the drugs that depend on CYP3A4, maybe there's more drug interactions than we even appreciate. Now, we tend to be black and white, a slow metabolizer versus an extensive metabolizer. Maybe there's sort of, there's something in between. And so, for example, like lumateperone, the starting dose is 42 milligrams, and we have these 10.5, 21 milligrams for so-called special populations, which you reminded me of with your question. In special populations, people who have, hepatic insufficiency or take concomitant drugs that inhibit the enzyme CYP3A4 to a greater or lesser extent. And then I got thinking to myself, I wonder if there's a lot, I'm not advocating this. This is a hypothesis. I wonder if there's a lot of patients that might do better on 10.5 and 21, not because they are, well, we're all special, I guess, a special population, but I wonder there's a lot more slow metabolizers than we really appreciate because A, people are taking things we don't know about. Second is, I've always wondered to what extent, what is the effect of all this fat in their liver? Half of our patients have fatty liver on cytochrome P450. So I guess one hypothesis is it has no effect. Don't worry about it. There's bigger things to worry about in life. The second is maybe some people it does have an effect because inflammation does decrease the activity of CYP3A4.
That's really important. I did not know that either, Roger. I'm always learning stuff from you. It's great. Hopefully we learn from each other. But
for sure, 100%.
Yeah. So you're making me think of something else here, which is we do tend to focus on the liver when we're talking about pharmacokinetics, and rightfully so. And parenthetically, I bumped into our friend Sheldon Prescorn at the Nevada Psych Association's past weekend. He's the guy who first taught us about CYP enzymes, especially with the SSRIs. I remember vividly, and he's been such a gentleman to me. But we have to remember, and I alluded to this earlier, there are actually many ways that we can have pharmacokinetic interactions. And one area that I really think more and more about now are certain transporters. And there's a whole family of transporters. One of them is the PGPs. And these are transporters, Roger, at the level of the gut, the kidneys, the renal tubules, and the blood-brain barrier. And they are genetically determined, just like CYP enzymes. Some people are faster or slower metabolizers. Some of our medications are substrates for PGP, some are not. So that is a whole nother, and the FDA has more recently started requiring companies to test and find out if their drug is a PGP substrate. And so you'll find that now in the prescribing information. And that just got me thinking that there's probably a whole bunch of other kinds of factors here. And so we probably should be careful. And I think the question then is, of course, how to monitor, how to educate our patients, what should we tell them? Hopefully we've got people starting to think a little bit about the kinds of factors, the things to evaluate, the risk-benefit notion, remembering that sometimes these things are justified because the risk of inadequately treating the illness is so bad. So I guess one thing that I think practically we can recommend, of course, is remember that our patients may see other providers and they end up accumulating medications. And Roger, you might have heard me tell this before. It's a little bit of a funny story, but I like to use the shopping bag trick, which is I get a patient to fill up a shopping bag with every pill bottle in their house.
Right.
But it's prescription and over-the-counter. Let's not forget over-the-counter meds, which we haven't even begun to talk about.
Yes.
And you will be shocked, Roger. I'll tell you, you'll see medicines prescribed by someone else that you had no idea they were taking. And let me tell you a quick story. You can't make this up. I had a patient one time who had a bottle labeled lorazepam and another bottle labeled Ativan, and she was taking both. She was wondering why she was dizzy.
Yeah.
I've had patients taking a bottle labeled benztropine and another labeled cogentin. So I think we can do a lot of good cleaning up our patients, if you will.
I think that's a sage comment, and I agree. When we do that, we do this kind of house cleaning of the medications. They bring the grocery bag in, and I kind of almost say, it sounds funny, but it's true. I'll say, which ones do you take, Mr. Jones or Mrs. Jones? Oh, I take the white ones. And, it's just.
Or my white pill recently turned blue. I got a new pill from the pharmacy. Yeah.
This is an opportunity, just a bit of a plug. Joe Goldberg, good friend of ours.
Love Joe Goldberg.
And about 50 of our colleagues, under the aegis of the ASCP, this is the American Society of Clinical Psychiatry and Variation Cycle Pharm, has a deprescribing guideline that we're working on right now.
Yes, what a fantastic idea.
We're doing it as a sort of a Delphi method. So it's more of a kind of a survey of experienced clinicians on a variety of drug combinations. And the impetus for this was what you and I have talked about, Andy, the frequency of polypharmacy and concerns out of futile at best and at worst dangerous drug combinations. But I think a practice reflection I've had as a person who's worked as a psychopharmacologist, running a psychopharm program for so long, is that I started to find over the years, Andy, that I actually deprescribe more than I prescribe. So we started thinking, why don't we create a deprescribing survey? So we hope to have that completed over the next, we should have it completed. We have to have presented at a conference in the spring, and get it into a manuscript and get it out. I think it's going to be really interesting just to hear people's opinions on deprescribing. And again, that's not to be equated with any type of stigma. I think we're not saying that people shouldn't be on psychiatric medications. That's not what we're saying. We're just saying that futility and counter-therapeutic combinations probably shouldn't happen. But in psychiatry, there's also a lot of gray zone, as we all know. And And a lot of times we're treating more theory than we really know what's going on. And it's always good to hear what consensus is amongst your colleagues.
I think that's going to be a super valuable resource, Roger. I'm so glad you guys are doing that. And I guess you might have heard my joke, which is I feel like I've done more good in my life taking people off drugs than putting them on drugs.
Yeah.
And there's some truth to that. And what ends up happening is people accumulate. You mentioned the Velcro effect. I've never heard it described that way. I love that. It's true. People just sort of add to. Yeah. They don't, or, you're meaning to switch and you get caught in the switch. You know what I mean? You add a drug, I'm trying to cross taper, and they get better. And now you're afraid it could be the combination that's making them better. And so there's many ways that people end up on polypharmacy. We use drugs to treat residual symptoms and so on. Okay, I think believe it or not, Roger, man, this hour went by fast. We're into the end, and there's still so much more I feel like we could talk about. So we'll just have to do it again.
Absolutely.
But I think we want to just leave our audience with some real practical tips. And that is, first, maybe organize your thinking around pharmacokinetics and pharmacodynamics. Don't be afraid to combine medicines in these treatment-resistant patients. Make sure you do good, careful, informed consent. Document, especially the reason, you're doing it, why you think the benefit outweighs the risk, and what your plan is. Monitor, and reevaluate as you go along. Now, we didn't mention clinically, of course, we talked about monitoring. You're going to monitor for side effects. Certainly, we monitor for movement disorders and so on. We didn't talk about, obviously, EKG is important in some situations. Clearly, vital signs are critical. Laboratory tests. We didn't talk about the risk of electrolyte abnormalities such as hyponatremia. We didn't talk about bone marrow toxicities, so worrying about neutropenia and so on. So there are some of the medications that you need to do those kind of tests. We talked about LFTs a little bit and so on. But any final words as I wrap this up with a bow, Roger? Any other advice for our colleagues?
As always, Andy summarized it amazing. I don't have anything to add, just to say that too. I think that we want to potentially avoid potentially dangerous combinations. At the same time, we also don't want to shy away from the fact that many patients do require combinations, rational combinations. We're treating serious illness. People are suffering. And it's always the balancing act. So I don't think that the philosophy is that combination's bad. We're not saying that. I think we're trying to find people a safe, effective combination. But no, Andy, awesome. Always fun to do this together, and look forward to doing it again.
Yeah, and if I could just put in a plug, you mentioned our friend Joe Goldberg. Joe Goldberg and Steve Stahl have written a handbook on some complex psychopharmacology. Joe and his wife, Carrie Ernst, have also written a terrific book on managing side effects of medication. So there are resources out there. And speaking of resources, Roger, for more information on our podcast, you can find our podcast anywhere you get podcasts. You can look under NEI Psychopharm, or you can search my name as the moderator, that my name brings them up. And for more educational offerings, more information about our live meetings, you can come see me and Roger live. Please come up, shake our hand, ask us questions, take pictures with us. Just don't confuse us, okay? I am the smarter, better-looking one of the two. Roger is the taller, more athletic. No, I'm kidding. People sometimes do that, but please come up and see us. And for more information on all of these, I'm joking, please go to our website, which is neiglobal.com. That's neiglobal.com. Thanks so much, Roger. Take care.
Take care, everybody.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.